So welcome everybody to SEVA VentRounds. Today is November 25th, 2025. And the question is this good? And this is the ventilator response. There's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And here are our disclosures. These are the ground rules. Just keep your microphone muted. And if you want to comment, use the chat function too. Remember, there is guidelines, and here we go. So already somebody has commented that this is pressure control, CMB, and we were going to talk a little bit about why this was. What's happening here? I'm sorry, I don't know what's happening to the system right now. 4, and here's 5. So there's 5 breaths to discuss. And there we said that this is pressure control because the flow is not controlled. But then we said that this was CMB. And so if we look at breath, at the first breath, who triggered the first breath? The machine or the patient? The vent, great. So it's definitely the machine. And we know that because there's no change in color. And we can see the change in color actually on the second breath. You can see that white changing the line. So definitely there is, this is machine trigger. The second one is machine triggered. So that, sorry, patient triggered, but it's machine cycled. And we know that because there's an inspiratory pause. So there's inspiratory time and there's no flow, which means that the machine has to be controlling the cycling. So for breath number 1 and breath number 2 are definitely mandatory. Rob, do you agree with that?
Absolutely.
All right. Then we go to breath 3, and breath 3, we know now that it's mandatory, and we know that because it's triggered by the machine, and so that makes it mandatory. But then we go to breath 4, and breath 4 is triggered by the patient, but the I time is shorter. So that would be atypical for a mandatory breath. It should be the same length. Correct, Rob?
Correct.
So something has happened here that is different because you can see breath number 5, and that's triggered by the ventilator, but it's cycled by the machine. So this is one of those that if you are just doing the analysis of the mode by looking at the waveforms, sometimes these are the things that catch your attention, that something is not as usual. And we're going to talk a little bit more about that. Without a doubt, all these breaths are mandatory, but there's a reason why that time is shorter, and we're going to get into it in a second. I'm going to move these 4 a little bit higher so that we can see the waveform better. And so there you go. So now I would ask you, what's the load? Elastic, resistive. Oh, so and it's adaptive. Sorry, because it adapts the pressure to the circumstance. So it's elastic, resistive, or PMOS. What's the load? Yeah, Fernando is jumping and saying this is PMOS. Jorge too. The whole team is recognizing this doesn't look like it should, which it would be an exponential decay. You see a lot of activity there of PMOS. And during exhalation, at least it seems that there is some activity here, and I don't know, over here, maybe. It could be. So I would say that PMOS is probably the dominant, but at least on breath number 3, which seems to be passive, it goes in and it comes down very fast. So I would say that this is probably an elastic load. Rob?
No. How do you determine an elastic load, a high elastic load from an expiratory effort?
So that's a good question for the team. So how would you say that it's an elastic load from the expiratory effort? Is that the question, Rob?
Yeah.
Well, if there's expiratory effort, you can't see it, correct? Or what do you mean by that? Can you specify a little bit more?
Let's start with the basics. If it was a passive exhalation,
Yes.
what would that look like?
Like
Smooth exponential, right?
Yeah.
Okay. And so if that was high elastic load, it would have a short time constant, just as you have indicated. It'd go back to zero quickly. Now, it's deformed in the negative direction, right?
Yes.
So the only thing that can deform flow in the negative direction is active exhalation.
Correct.
And so I would argue that this patient looks like they're actively exhaling, even at the point when the ventilator triggers a mandatory breath. And because they're breathing out and the ventilator is breathing in, you get a very low inspiratory flow and a very small tidal volume that goes with that, which looks like a very extreme elastance, because the ventilator doesn't know the difference between, mechanics changes like elastance and compliance versus PMUS.
Excellent. Very good observation, Rob. So this waveform that we see here could have two potential explanations. Explanation number one is that there is activity of the expiratory muscles. And option number two is that the patient actually has infamous elastic or very high elastic load. You suspect that this is the case because there is activity of the expiratory muscles during exhalation. Correct, Rob?
Correct. And you see confirmation by looking at the very first breath. Same thing has happened, but the patient stops exhaling midway, and then you get flow.
Excellent.
So if it was a compliance problem, it wouldn't look like that. It'd be smooth exponential, right?
Very good. So now let's go into the part which is the discordances. So for breath number one, what's the triggering issue? Normal, early, late, false, or failed?
For which breath?
Breath one. The first breath. Yeah, very, very good. So I think everybody is recognizing that this would be classified as an early trigger, just because there's a mandatory followed by PMUS. Now we can argue about if that is because the rate is so high and this patient has its own rate, or because it relaxed. I mean, whichever way we want, this is the first breath would be considered an early trigger, which then makes the second breath a double trigger. We would not classify that. Rob, any disagreement there?
Nope, I think that's right on.
All righty. And then comes breath number three. And I mean, Rob has made a very nice argument that this breath that got delivered didn't go fully in because of the patient is exhaling. And then you have a breath that gets triggered just immediately after the exhalation starts. So breath number three technically would be normal, but breath number four will trigger another one. And so Ariel is saying, this would be an early trigger. So you have the mandatory breath followed by PMUS, and actually caused another trigger. Rob, what do you think here?
Well, I sort of go with what you said for the beginning, because the breath is defined by the flow crossing zero positive and crossing zero going negative. So there's a breath there that you can see where the two zero crossings are in the flow. So that's one breath. And then immediately after it crosses zero, within a few milliseconds, the patient makes an inspiratory effort, and this is pressure triggered, big enough inspiratory effort to pressure trigger two breaths.
And this is one of thank you very much, Rob. So technically, so what so I want just for you to take a second to recognize one of the items that occurs right now when you're thinking about machine learning and reading about these waveforms, or you per se. If you take breath 1 and 2, you would say early trigger easily, right? Early trigger leading to double trigger. If you see breath number 3, 4, 5, if you saw breath 3, you could say, well, these started in the early expiration, so breath 3 is normal, and 4 and 5 is a breath that was early cycled and led to double trigger. Or if you see the prior one, you would say, oh, this is just a pattern of early trigger, and this is a phenotype of early trigger in which it triggered in the early exhalation. And I know that this is like getting into the weeds, but it talks about the challenges of classifying these things. And if you see the phenotypes for reverse trigger, you're going to see the challenges that it comes from this type of discordance when it happens in the early expiration. Rob?
Yeah, it gets very detailed, and as you indicate, I don't think we have consensus on how to think about these things. I have one way of doing it. It may not be the right way, but I define a trigger event as something that happens during the expiratory phase, when the flow is below zero.
Yeah, that's exciting. So just keep that in the mind, back of your mind, that there is some challenges, but I want you just to recognize that right now, if you see this in context, these would both of them would be an early trigger. Now, there's a question here from Rowdy that says, the breath flow that reaches zero just before breath number 3, isn't that triggered there? Why isn't that considered a false or failed trigger? That's a great question. So Rowdy is talking about these aberrancies that are occurring, or changes in the flow that are occurring in this waveform. And certainly, Rowdy, this could be a issue. This could be either failed triggers, or it can be also cardiac oscillations, as Fernando is putting, or it could be uneven activation of the expiratory muscles, kind of I'm not going to say quivering, but they relax a little bit and go. And that's the problem when you're seeing the waveforms for flow, that every little thing that happens with the muscles can be seen and may cause you to wonder. So you're absolutely right. And the only way to confirm this, Rowdy, is if we have an alternate method to look at PMOS. This may be an electrical activity of the diaphragm with a NAVA catheter, or an esophageal catheter can help us see that. Rob?
That's exactly right. But given what we have here, would you like to speculate on what the PMUS inspiratory and expiratory durations might look like, starting around the middle of breath 1? Or is that
So let me
too speculative?
I love what Rob is asking. So I'm going to put in yellow. So the question is, how long does inspiration and expiration last here? And so let me start with this breath over here, and the PMOS you're asking, right, Rob?
Yeah, PMOS. Show us PMOS.
So if I would talk about PMOS, I would say that PMOS started here. And actually, I'm not going to even draw. I'm going to draw a line that highlights.
Yeah, draw a line. Yeah.
So just like that long, I would feel that it goes, Rob. Do you agree with that one or not?
I'm thinking that it goes into the expiratory time, because I think it's clipping the peak expiratory
all the way
flow.
over here.
Yeah, right there.
Well,
That's
then we would expect this one over here.
Yeah.
Well, I think that's where Rowdy is coming, that these may be PMOSs that are occurring here, like smaller ones, or cardiac oscillations. Because if there was PMOS going all the way over here, I would expect the flow to be higher. I would expect the flow to continue to rise over here, actually, and then go into this phase. And so I would expect more flow than what I'm seeing here, Rob.
Unless it's occluding. I don't know.
But why would it be occluding? It's pressure control.
Okay.
So I think that the PMOS goes from here to here.
Okay.
And then expiratory goes here, and perhaps there is some activation of the expiratory muscles, as you were saying. The pressure does go higher, so I'm wondering if there's some activity of the expiratory muscles ongoing here.
Yeah.
So that expiration would go from here to here.
Yeah. I agree with that. Yeah, that makes more sense, right?
All right. So just to recap, because we talked a fair amount. So inspiration would be these, so inspiratory muscles, and expiratory muscles would be active, we think, from here to here. With some oscillations there, Rowdy, as you pointed out. So it's not a simple breath analysis, just to put it out there. Okay?
Yep.
All righty. Any other items here in terms of discordance? Okay, so now I want to go back to the question that I had posed at the beginning. Oh, there's a question that came in. The ventilator senses the change in flow, but the pressure transducer also records a small negative deflection. Oh, is that the reason, Karsten, that it marks up here? All right, we'll come back to that. So team, now I want to go into this the conundrum of why breath number 4 is shorter. Anybody has any thoughts of why breath number 4 is shorter? And I'm gonna put it. I actually put this graph over here. We can see it here again. But why would, so Arcel says, well, probably goes to breath number 2. So normally, and I think that this one shows it a little bit better, or perhaps this one. So the reason, Arcel, and let's focus on this waveform for a second. So it's the same mode, same patient. I just took the picture at different times. So just for the sake of it, breath number 1, do you agree, Rob, that this is an passive breath?
Yep.
Beautiful.
Yep.
Triggered by the ventilator.
Yep.
Nice. And it's aiming at a tidal volume of 300. So this is 500, probably 250 is right there. So it's pretty close, pretty darn close. Second breath is triggered by the patient. However, you can see that the height of the pressure waveform is much higher than the one that was not triggered by the patient. So that's observation number 1. I'm going to put it over here. Observation number 1. The patient-triggered breath has a higher pressure than the machine triggered. You see the difference, right? Much higher pressure than this one. And actually, you can see that also on the next breath. It's triggered by the patient. So this is patient-triggered, patient-triggered, patient-triggered. This is machine-triggered. And you can see on the patient trigger, again, very high pressures, and the next one, high pressures. And I'll go back to this one, and you're going to see machine triggered, little pressure, patient triggered, higher pressures. So that's observation number 1. Observation number 2, the ICU fellows are asking, is there a safety lockout feature? You're pretty close, ICU fellows. So the second feature is look at the tidal volume between the first breath that is mandatory, and the second. Yeah, absolutely. And the second breath, you see how high the tidal volume is? And the same for this one. So the breaths that have a shorter I time have a larger tidal volume compare it to this breath, the breath in the middle that was also patient triggered, that the tidal volume is not as high. And if I go to this graph that I had shown you here, you will see the same thing. Patient triggered, breath number 4. Patient triggered, breath number 5. The tidal volume for breath number 4 is very large. For breath number 5 is not as large. So that's the second observation that I would like you to have, is that in some of the breaths, the shorter breath, the I time is shorter, the tidal volume is larger. So here comes the explanation of why this is happening. And this is reverse engineering in ways. So there's the reason why the first observation is that the patient triggered have higher pressure and the mandatory have lower pressure is because, and unless the Mackay engineers come and say otherwise, there's two adaptive algorithms occurring at the same time. One of the adaptive algorithms aiming at the tidal volume of 300 is for the mandatory breaths, so the machine trigger breath, sorry. And another algorithm is for the patient trigger breaths. So that if the patient triggers, they will get the pressure an adaptive algorithm for patient trigger breath. So there's two algorithms going at the same time, one for the mandatory and one for the spontaneous breaths. And that you can see it again here, higher pressure, sorry, in the one that I was showing. Higher pressures for patient triggered than for mandatory. And that's a nuance of this ventilator. That doesn't happen on all ventilators. The second observation is that the IT is shorter when the tidal volume is larger, has to do with a safety feature that occurs on this ventilator, in which when the tidal volume has reached, I think it's 1.5 times the tidal volume that you said, so meaning 450, it will cycle off. So the patient took a breath in, it was continued to do effort, and it triggered the next breath, but it reached to 450, and so boom, it cycles off the breath. And so that's why you get a shorter I time. This is not the patient cycle, it's a machine cycle, just to try to limit the tidal volume that the patient gets. And you can see the example here. Here it caused a double trigger. Here it caused a double trigger. The PMOS kept going from here to here. In the next breath, it triggered, and the PMOS went all the way over here. So it was not strong enough to trigger the next one, but was it strong enough to generate larger tidal volumes? So the message, just to recap, is that PRVC, or this PCCMBA, is not the same on all ventilators. And in this ventilator, it has a targeting scheme for the machine trigger breaths and the patient trigger breaths. And it has an algorithm or a safety feature that will cycle off the breath on time. So you can see that happening here. Large tidal volume, not a large tidal volume, so I give the full I time because I didn't get there. Short I time because I got a large breath, short I time, and then a long I time because I didn't get to that safety threshold. Rob, comments?
I remember that we had a discussion with the engineers about this, but I don't recall what the justification was for two different algorithms for a machine-triggered mandatory versus a patient-triggered mandatory. Why would they be two different? That doesn't make any sense.
I don't know.
Two different targets, yeah, for pressure.
Yeah, and especially that becomes an issue in patients that are active or that have reverse trigger, or early trigger, like we were seeing here. So what would have been your solution for this patient? If you want to put it on the chat, how would you solve this situation? The patient is on 90% oxygen, is probably on a SAT at this time. We dropped the rate, and you can see that I dropped the rate to 11. So we were at 20. I dropped it to 11. I dropped the tidal volume. I think I adjusted I didn't touch the eye time. That's what I had done, and it's still happening. So PRVC is just not cutting it. What would you guys do? This patient is on 8 of PEEP, 90% oxygen. I love, Karsten, when you come up and say, what's the goal? So I would say that this is a mixed goal. I would say that it's safety, comfort, likely. Yeah. Thank you, Jorge. Yeah, I agree. Safety, comfort. I'm looking at the screen. Have no fear. I mean, as you well know, when you're in front of the ventilator, now you have your goal. You say, well, my goal is safety and comfort. I'm waking up this patient, still on a very high FiO2. The PEEP is low. Elastic load, a fair amount of PMOS. What mode would you use? What would you change the mode? Would you sedate the patient? Would you go running away and cry under the table, which I have done a couple of times? Come on, fellows, give me an answer.
Just guess.
So now the early trigger has gone away, but you can see that patient doing PMOS larger, and it's actually double triggering. Yeah, this is Benjamin. This is only for the servo U to my knowledge. And I can tell you, Benjamin, that's a great question. Is this for every mode or not? The answer is this is not for every mode to my knowledge, but we see it because we take care. This is our mode, and when we are attuned to finding these errors. Or these challenges. So when I walked by, and Ariel was completely right when he said that these look like volume support. So auto mode PRVC volume support. And I agree with that, but it says PRVC here, and you can see the different eye times for some of the breaths, and then those that look like the cycling is mandatory. But it turns out to be just a safety feature. So I see a comment here from Rowdy. Thank you for jumping up. If the patient is an SAT and not ready for extubation, I would consider resedating. It's not ready for an SVT with such large FiO2 requirements. I don't know much else about the clinical situation. That's right. I mean, I'm cheating here because I'm not giving you everything. But from the concept of what you can do for this patient is you want safety. So you want to ensure that there is, that there is a mandatory or minimum gas exchange that the patient can get. And then on the other side, you want to ensure that this double triggering goes away as much as possible. Because this patient is getting not 250, it's getting around 450 plus 250, so 750, probably 3 times the amount of volume that the patient wants. And we know that changing this patient to volume support will not improve anything, because in volume support, the rule would still apply, and it still applies. So you're left that the algorithm, the intelligent algorithm, is acting against you. So what we did is to shift the patient to pressure support, to auto mode pressure control, pressure support, so that still would have a backup rate that could keep the patient, at least while we're doing the awakening, and then allow and see what the tidal volume is doing. And now you can say, Eduardo, you're nuts. Look at the tidal volume, it's 10 cc's per kilo. And I would argue that, I don't know why I did this. I don't remember the exact goal. And at this point, you would have to say, well, that's unsafe. Maybe we need to resedate the patient. So going along with what Rowdy says is that your goal is safety, then sedation. You're not achieving it with it. You can see that I'm down to 10 of pressure support. And if the goal is comfort, then this mode is likely to be more supportive of the patient, work of breathing, and get rid of those unsafe hyper large tidal volumes. But again, it's not meeting safe targets right now. Rob?
This is a perfect example that comes up sometimes in our SEVA courses of why are there 3 different kinds of auto mode? And specifically, why are there 2 kinds of auto mode that are pressure control? Well, this is the reason. Because if you have a patient with a large inspiratory effort, then the pressure PVRC type of auto mode will cause problems, because not only does it cycle early, but it also starts to decrease the support. So you got 2 problems. So if you put the patient into a set point targeting instead of adaptive targeting, you might be able to get away with comfort like this, and the patient isn't making such a big effort that they're excessive tidal volume dosage. This could have been, 7 or 8 mLs per kilogram, and the problem would have just gone away.
Yeah, that's wonderful. So let me just recap for all of you these moments. Number 1, we saw that PRBC, PCC-MBA, we saw an elastic load, PMOS present, and actually the expiratory PMOS present impeding the delivery of the breath, which is breath number 1 and number 2. We also recognized early trigger, and we talked a little bit about context, how the prior and the surrounding breaths help you understand if this is early trigger or if this is just simply a trigger that occurred afterwards with a very high PMOS. We also talked about the different ways that PCC-MBA can be implemented in different ventilators. And this is one that was a surprise for us, and we learned as we took care of patients. And it was that the mandatory the machine triggered and the patient triggered breaths had different algorithms, and that there's a safety feature that cycles the breath when it delivers 1.5 the tidal volume that you have set when you're on PRBC or on volume support. And finally, that there is different types of auto mode that can help you deal with these interactions, and then you have to make a decision of, well, is this safe target of tidal volume appropriate for this patient or not, and make decisions about how you're going to take care of them. So I hope that this was relevant and useful for all of you. I know that this was not an easy case, but it's a juicy, meaty case for your brains to say, that's why we need to know how to manage and adjust the ventilators. I hope that you have a happy Thanksgiving, and we thank you for being with us today. Again, register for the SEVA for the SEVA Summit, which is coming in April. The spots are going fast, and we would love to have you. A lot of new stuff coming through for you to get better at it. Thank you very much, and have a great Thanksgiving. Bye-bye. Thank you, Roberto.